Hello, partnering for vaccine equity learning community members and others working on vaccine equity, and welcome to this afternoon's learning event. My name is Kristen Brown, and I am the Deputy Director for Group Learning. And on behalf of our team at Urban Institute, thanks for joining us today. Today, we will hear about how we can use national survey data to guide our community level strategies for advancing vaccine equity. We are excited to hear from Richard Corderone from the CDC, who will present recent findings on vaccination coverage and intent from the National Immunization Survey. He will also give us examples of other resources that community-based organizations can use in their programmatic efforts. Before we go further, I'll do our typical review of how this session will work. You've all been muted upon entry to this session. There are a lot of us, so staying on mute, unless you're speaking, is key to keeping the discussion going without accidental interruptions. You do have the opportunity to speak your question rather than type it into the Q&A. It's your choice. If you want to speak your question, use the raise hand feature and we'll unmute you. If you want to type your question, use the Q&A tab to do this, and you can ask a question at any point during the session. The chat room feature is also open today, and we encourage you to chat amongst yourselves as you'd like. But please use good chat room etiquette. By this, I mean do not post questions for the speaker in the chat because we might not see them. And though this probably goes without saying, please be civil to one another and our speaker while chatting. We have begun offering live interpretations from English to Spanish during our events. If you would like to listen to the Spanish language channel, simply click the globe icon in the Zoom taskbar at the bottom of your screen. Finally, as with all of our learning events, we will post the slides and a recording of this event on our paid learning community website. If you are partnering for Vaccine Equity community member and do not have an account on the website, please register using the link that will be dropped into the chat. Event recordings will also be circulated through the digests that go out through the CDC managed Adult Vax Program listserv. If you have technical difficulties at any point during the session, send an email to our community manager's inbox at vaxequitylearning@urban.org. We'll be watching the inbox and we'll try to get to help you as quickly as we can. And now it is my pleasure to introduce our featured speaker. Richard Corderone is the Health Communications Specialist in the Immunization Services Division at the CDC, where he supports domestic immunization by helping health departments and partners build vaccine communication and confidence capacity. Richard served on the CDC COVID-19 response for 2 years, initially as a senior press officer and later serving as the Deputy Director for Communication on CDC's COVID-19 Vaccine Task Force. He brings 25 years of experience in public health, communication, and community organizing, and we are absolutely delighted to have him here with us today. And with that, Richard, I will turn it over to you. Thanks for joining us.
Great, thank you. I'm really happy to be here. So I'm going to talk a little bit about the data that we have, that we collect, how to use it, and just as a full disclosure, one of the things that it's great to have a lot of data and a lot of really interesting, valuable data. But one of the things that I've sort of consistently seen, and I know happens on the public health side quite often, is that we get caught in the data. And it can be debilitating, kind of looking at the data, sort of focusing on the nuance of it instead of taking action. And I know this group is very action oriented, so I don't think that will be a problem, but I always really want to point that out because we focus on the data so much and the different pieces of the data and making sure that we no data is going to be perfect. We're never going to have everything that we need in order to take action, but we can't let that stop us from taking action. So with all of those caveats, let's get going. Next slide. So the topics I'm going to cover is I'll give an overview of our data to action approach that we take in building vaccine confidence, and this is this is a standard approach. It's not anything that you guys probably don't do as well. but it's just sort of, that's what we call it. And that's kind of the way that we take a look at it in terms of taking the data and building strategy. I'm going to go through the vaccination coverage and confidence related data that we have and talk through a little bit about how to interpret it. And then I'm going to talk through some of the vaccine confidence concepts that we use just to kind of refresh everyone's memory, kind of get everyone thinking in those ways and talk through and give an overview of some of the resources that we have and where you can find them. Next slide, please. Next slide after that as well. So about the data. So what we do with the National Immunization Survey and with other data that we collect is that we try to get an understanding of both vaccination coverage. So who's vaccinated, where they're vaccinated, who's not vaccinated, and then the intent for those individuals who are not yet vaccinated. And in that, we kind of take a look at that and build all of that around the questions that are in the surveys, and the way that we look at data are built on specific behavioral and social science models that we know that align with increasing vaccine confidence and ultimately increasing vaccination and vaccine demand. We are going to look, when looking at the data, most of the data that we're going to look at is national data. There's going to be some state level data, or you can find state level data in it, but there's local data as well. And to know that, you know, when looking at these different types of data and using the data to drive your program and your priorities and your strategy, that you know, understanding how to look at the national data, the state data, and the local data together, as well as add any qualitative insights to the quantitative measures that we will often get, that we try to get in survey data and other coverage data as well. Next slide. So I wanted to put this model out here. This is the behavioral and social drivers framework related to creating vaccination demand and vaccination uptake. So just to kind of talk through it, starting on the left, it's really a fairly simple concept. I think that's one of the real values of this particular model. And it's not very different if you're familiar with the health belief model or ecological model. Taking a lot of the characteristics from those models and really kind of applying it here. So in starting on the left, we understand the thinking and feeling, you know, how people think and feel about the vaccine, about the disease. Do they believe the disease is an issue, a challenge, something they should be worried about? What is their personal individual risk? And then what is their confidence in the vaccine in terms of anything related to the safety or effectiveness of the vaccine? Not only as we often talk about it on the public health side, as sort of an aggregate population level, but for them personally, in their community, for their families, for themselves, for their children. And then what are the social processes? So these two things, the thinking, what people think and feel, and the social processes around them. What are the social norms? What do family members, religious leaders, health providers, friends, family, what are the norms that they have around vaccination? How do they perceive it? And when we look at social norms, this is a really important place to begin to understand and think about the role that social media plays in creating the motivation for vaccination and the intent to get vaccinated. A big part of the social processes and social norms are provider recommendations. And what does the family member, or does the individual or group or community, do they regularly see a healthcare provider? what is their connection to the healthcare community, and what have their experiences been. Those types of things really determine the role that the health provider plays in their recommendations and creating that motivation. And other issues like gender equity, racial equity, all those other social factors really play a role in it. There's very, as you guys are aware, very specific issues that people of color and women have often had related to the healthcare system. And intersectionally, when you put all of that together, that those social processes and their interaction with the healthcare system can really play a role in determining motivation and how all of these things connect. So if we put what people think and feel and those social processes together, that's where we get the motivation or the intent. And that motivation or intent kind of measured in thinking about how much do I want to get vaccinated? How much do I want to take this action? What are the other barriers? What are the opportunity costs? And once you've got that motivation, there's a whole bunch of other practical issues that really play a role. Is the vaccine available? Is it convenient? Is it affordable? How easy is it to get? Are you going to have a positive experience with a provider? What does the provider look like in your community? How do all of those things play a role? And in this entire process, so if any one of these things can reduce the likelihood of vaccination. So putting all of that together, and you could have the greatest motivation, the highest intent to get vaccinated. And if those practical issues are not met, that not only undermines the motivation, puts up barriers to getting vaccinated, to seeking care. It's not even just vaccination, but it's any type of care or interaction with the healthcare system. If those practical issues are not met, not only does it harm the initial motivation for that specific thing that we're looking at, say a vaccine, but it undermines trust in the system. And that's really key to all of this, is that getting the practical issues right, getting all of the pieces together in terms of creating access to safe and effective vaccines, and building out the motivation, we have to really kind of think about all of those different drivers. And then all of those things are the things that have to happen in order to get somebody vaccinated. Next slide. And so when we look at the data that we're going to be looking at and talking through sort of building a vaccine demand strategy or an outreach strategy really at all, the data that we're looking at really are just one piece of the puzzle. This is sort of the approach that we use in terms of building a strategy. And these data that we're looking at today are the first data that you look at. Sometimes they're the last data if you're sort of thinking about evaluating the work that you're doing or assessing the work that you're doing, and thinking about sort of changing strategy, updating strategy. But it's primarily, this is your starting point, understanding who's vaccinated, who's not vaccinated, and then any details about demographics, geography, and then building into motivators. So just very quickly looking at this whole process, starting with the vaccine and community data, the specific, that's really largely the quantitative data. You guys have likely done some type of assessment or understanding work to do some type of community assessment to build and understand your strategy development. And often that's qualitative data, getting an understanding of what's going on in the community. We have a process that we use called a rapid community assessment, where we identify specific areas or communities, populations that have lower vaccination coverage, and then have a participatory assessment process that's very deliberate in making sure that we're understanding and identifying all of the barriers and facilitators to individuals or groups getting vaccinated. And we use that to really kind of build our strategy. That's where we get those data to the action component of it. And so most of this is really the action and understanding the outcome of those actions to building in the center health equity. So we have the strategy development leading from the assessments and the data, and then implementing the strategy. And again, the strategy that we're implementing is not just outreach. It's not just communication, it's really engagement, really understanding and ensuring and working with partners, working with health departments and others to ensure that all of the pieces are in place for somebody to be able to get vaccinated and have confidence in the system that allows them and encourages them to get vaccinated. And of course, we evaluate and then we start over again, looking at those quantitative data on coverage and intent. And at the center of all of this, we put everything at the center in public health around equity and around issues of justice. And keeping that, at the core of how we're implementing and supporting all of our programs, how we're collecting data, what data we collect. So next slide, please. So the data sources that we're going to look at include and all of these, for the most part, these data are public and accessible on the web. We have some new data that are not. And so you can get to all of these data either through the CDC website, and we're going to include one data source that is not a CDC data source, but it's actually a Kaiser Family Foundation data source, and they've been doing a lot of great work in consistently doing national level surveys over the course of the last year or two. So we'll start with the COVID data tracker. This may be the source of information that you're most familiar with. It is the sort of the data that are reported or shared from your state or local immunization information system, from your state or local health department. And that's basically you got vaccinated, we'll collect your information, put it in a database, and use that to make sure that we got documentation of your vaccination. State and local health departments share those data with CDC, and we put that on our website in the COVID data tracker. So it's that very tactical day-to-day vaccination data. Those data are great, and they can be very actionable. But one of the things that we have a long history of producing the National Immunization Survey. The National Immunization Survey is something that we developed really to assess the Vaccines for Children program. And since initially creating the NIS, we've added additional modules. And two of the more recent modules are the adult COVID module and the child COVID module. So these are representative samples that we're able to get not only of vaccination coverage, which we can then level check with the data from the IAS to make sure that the data in the IAS are aligning with what we're seeing in terms of our surveys, and identify possibly any issues with the IAS or any issues with the survey when we are able to kind of compare those two. So that's actually looking at those two things together is really exciting, really positive, and it's not something that we've been able to do uniquely during the COVID response. And the National Immunization Survey, because it is national, we are able to get jurisdiction level really mostly down to the state level because of survey sample sizes for COVID vaccination, as well as intent and looking at those behavioral and social drivers that we talked about in the previous slide around the behavioral model. Some of the new data that we have that I'm going to include a little bit about The Census Bureau does a household pulse survey, and these provide state level estimates of parental intent with their children. So this is a census driven survey that they use as and get a sample of folks that they have counted in the census. So this is really kind of building on that. So it's not our data per se at CDC, but it is data that we use again to help level set and help understand intent. We also, I'm going to talk a little bit about the State of Vaccine Confidence Insights Report. This is qualitative data that we, again, use to level set, check against things, check against the different intent data, maybe dig a little bit deeper into some of the details. So this is qualitative and quantitative analysis of data, different data sources, largely digital, but not all digital, as well as media sources. So digital social media, Google Trends, those kinds of things, as well as a variety of different social media platforms, as well as things like CDC info. So are we seeing, if we're seeing something sort of pick up on social media, is that reflected in what we're seeing in terms of interaction that we're getting from the public through CDC info and other sources? Because social media, because it is engagement driven, you can inadvertently identify outrage or concern that is not, that may be a bit of an anomaly. So again, having those level sets and those checks. And these data are really used for creating themes and recommendations for action, maybe more specifically than the data that we would get with a little bit more detail than what we would get maybe in the national immunization surveys. And I mentioned as well the Kaiser Family Foundation highlighting some of the data that they have as well. Next slide. Next slide. So yeah, now we're going to talk about some of the coverage data that we have. So we've basically, this slide pulls two graphs of vaccination coverage by age group, starting with 5 to 11, 12 to 17-year-olds, 18 to 24-year-olds, breaking it out in relatively small groups, sort of 10 to 15-year breakdowns up through age 75 plus. What you'll see is that we have two graphs showing individuals who've received at least one dose of vaccine and those individuals who are fully vaccinated. And these are always measures that we use if you have multiple doses of a vaccine that is necessary. It gives us the opportunity to sort of level set and understand sort of where to put resources as we're building programs. But it's also important with COVID because for a long period of time, we did have a single dose vaccine. And so differentiating between the at least one dose versus fully vaccinated was really important in kind of thinking through our planning. So these data you see with adults 16, 18 and older based on when things were recommended. You start to see a really big uptick January through July of 2021. You start to see it level off a little bit for all age groups. The oldest age groups are the ones who most from the data you can see are the ones who are most likely to have completed their series, they got their first dose first, they were fully vaccinated first, and they are really kind of the leading indicator. And as you go down in age, you begin to see a difference in decline, and this has to do with largely, I think, a perception of risk, and again, some of those behavioral factors really kind of playing into it. And we'll get a little bit into that in a bit when we start talking about intent. And you will see the youngest age group, the 5 to 11-year-olds, as well as the 12 to 17-year-olds, pick up later because they were authorization for those vaccines came later than they did for adults. So those are, again, a lagging indicator. And you see that they are not as fast or as high to go up. And again, these have to do with some social norm issues as well as perception issues of risk versus benefit of vaccine. So only about, just to kind of give an idea right now where we are, we have that highest coverage and where we are with 5 to 11-year-olds specifically is about 35% have received at least one dose compared to the big number across the board number of 82% for the entire US aggregated population. So again, I don't think there's anything surprising here, anything that we didn't already know, but again, it puts it into really good, quantifiable, understandable breakdown. And these are, for those of you looking at it, like these are literally screenshots from the COVID data tracker. So these are data that you can pull, graphs that you can pull and put in your presentations. And because these surveys are done on an ongoing basis, these data are updated very regularly, though in the last couple of months, we have not seen a big uptick, but making sure that you guys do have access to the most current data. Next slide, please. So digging in a little bit more and starting to get into intent. So we have the National Immunization Survey, and we're looking at the children, we're looking at the adults first, excuse me. And we have a couple of different breakdowns of how we're looking at vaccination, vaccine intent, and how people are perceiving things, and where we can identify very clearly groups that are having the greatest challenge or who are not really kind of perceiving the risk or have the most resistance or lowest intent to get vaccinated. So first, these data are not quite as up to date as the previous slide, which had gone through the beginning of April. This slide has data going through the end of March. But there really, I'll say there has not been much change since then. So we have it broken down by age group, whether or not someone is in an urban suburban area versus a rural area. And then we have it broken down by race and ethnicity. And what you can see is that individuals just kind of across the board, again, reflecting what we know, and this is also looking at one or more doses of vaccine. As the older individuals are more likely to have gotten their vaccination, and as we get to the definitely or probably will get vaccinated, those ribbons in the lines are getting smaller and smaller. We know that this is a pretty common approach that happens when any new product is recommended or a new product is released. You have early adopters, sort of primary adopters sort of in the larger group and the bubble in the middle, and then it gets much more challenging to reach individuals who are more holdouts to, say, new technology or new product. So in terms of intent as well, you can see that as the sliver of individuals, and they definitely probably will get vaccinated, are getting narrower and narrower. As those individuals get vaccinated, the probably or definitely will not get vaccinated you kind of hit that roadblock as well. We see probably or will not get vaccinated much more likely in younger age groups, in individuals who are in less urban areas. So suburban, exurban, rural. Rural in particular is a much greater amount. And in terms of intent on race, ethnicity, you have the highest level of vaccinations sort of consistently among Asian communities, white communities, and among Hispanic communities. So white, Black, regardless of race, the Hispanic ethnic communities. And these, again, as you're looking at this, just sort of looking at it nationally, where intent is, there is a larger number, for example, of individuals in the Black non-Hispanic category that are still in the probably or definitely will get vaccinated group, and maybe those individuals need a nudge or they need improved access. But there are many fewer in the probably or definitely will not get vaccinated. So there's a lot more of a wait and see and really kind of understanding, or there are specific barriers or other motivators happening. Whereas the white community, the bar for the probably or definitely is getting really, really narrow. And this is for adults. So knowing that coverage is a lot higher among adults, just more broadly, they've had longer access to vaccination. The disease has been understood as more of an adult disease than a childhood disease, though those perceptions are early perceptions that have sort of lingered. It makes a lot of sense. All of these data make a lot of sense, and it can add some real focus to reaching specific communities and groups sort of at a broad national level. Next slide. It's a little bit of a different story when we get into children ages 5 to 17 years old. Right now, what we have when we look at all of this, we have overall children age 5 to 17. When you look at vaccinated is about 45, 46%. And when you add to that, there's about 5% of the definitely will get vaccinated, and there's a bigger ribbon of the probably will get vaccinated as well that probably pushes it up. That's in the 17 or so percent. So that gets us to 50, 65, 70%, which, you know, from coming from a marketing point of view, getting 2/3, 3/4 of any group, any population to do something or embrace something is really difficult, which makes it all the more challenging for what we do in public health, because really, you know, everyone needs to get vaccinated. So as we look at that, the overall, again, is about 25, 30% of the probably or definitely will not get vaccinated. So as we look at children, understanding the intent and the reasons for that become really important as we dig into that probably or definitely will not get vaccinated. Those motivators are really important. And similarly to the adult data, older kids have higher vaccination coverage, more likely to get vaccinated, and are less likely to have the probably or definitely will not get vaccinated. And there's some large groups of the individuals who maybe need a little bit of a nudge. When we start looking at the metropolitan area, the urban, rural, suburban looks very similar, though the numbers are lower. Medicaid and health insurance, these are numbers that we see a lot in the childhood as well. When we look at that individuals who have health insurance, they're more familiar, more comfortable with the system, they have more comfort, consistency in using the health system, are more likely to get vaccinated. And then those numbers go down when we look at different types of health insurance and healthcare access. So Medicaid, those on Medicaid tend to have lower coverage, and those who don't have consistent insurance or consistent healthcare coverage have the lowest coverage. A lot of other social determinants that are applying to that are influencing that as well. Again, the data look very similar, though the coverage is lower when we look at race and ethnicity as well. The one difference is those individuals who identify as multi-ethnic or multiracial have slightly higher coverage and have greater intent than those who either identify as white, Hispanic, or Black or African American. And that again becomes really important. And the Hispanic as well as African American also, they have slightly lower coverage, but they are in this group where they probably will get vaccinated or have some questions or are unsure. Again, these align with income as well in looking at kind of that lower side. Again, all of these data you can pull from the COVID data tracker. Next slide. So you can pull this from the COVID data tracker. You can also pull it from COVID VaxView. All of these things are accessible through the COVID-19 website. The COVID VaxView really digs into the survey data around intent, around coverage, and will allow you to, and I have a little screenshot of what the page looks like so that you know you're in the right place when you get to the site. But it can also break it down. It's interactive, gives you the national data, but allows you to dig into regional and jurisdictional level data. So by state, by districts, so like District of Columbia, as well as some of our funded local jurisdictions as well that have large populations, New York, Los Angeles, Chicago, Houston, as well. We're looking at large sample sizes. And then you can also filter by demographics, health behaviors, as well as some of the social processes that we talked about in terms of building intent. Next slide, please. And here I have, again, want to create some familiarity with the interactive aspect of the system and how you can break it down. On the left, we have information that you can pull on your different regions, national jurisdictional level. Do you want national estimates? Do you want to look at HHS region 1, 2, 3, 4, 5, 6, 7, 8, 9, 10? Or do you want to look at a specific state or jurisdiction within those regions? You can break it out on trends as well. So you can base it on your data collection period if you want to look at month by month, or if you want to look more granularly at the weekly changes, you can do that as well. And you can do it over the entire course of time that we've been doing the various surveys. The surveys for adults started before the surveys for children because the vaccines were available. And so the surveys align with when the vaccines are available. So that's roughly how far you can go back to understand or to look at the trends. And then you can also pull maps. I'll have some examples of maps, different maps that you can pull. And then the different intent profiles and indicators built into those maps as well. And then of course there's a link to data notes, and it'll pull up in either a spreadsheet on the bottom. It's very interactive. As you make the changes, they show up, and you can pull those data as well. So again, creating some familiarity, awareness of what the system looks like. Next slide. So some of the information that we pulled from the COVID VaxView. One is a chart on the top that shows, as we look at some of the behavioral indicators by age, 18 to 49-year-olds, 50 to 64-year-olds, and 65 plus, looking at how concerned individuals are about COVID-19 disease. And this goes back to October of 2021. And you can see that that particularly since it went down a little bit, and then as Omicron kicked up in October, November, and through January, the perception of risk of disease was higher for every age group. It's again important to note that the age groups that had the perception of the highest risk of disease were those individuals who were over 50, with a sort of clear difference between those who are 65 plus. But even that risk perception has declined over the last couple of months, and much significantly lower are individuals age 18 to 49, again, based on people's perception and understanding of risk. At the same time, we also looked at, also pulled some data, and this is in the lower left-hand side, looking at, again, these are national trends, work or school requirements for COVID-19 vaccination. So we have some school districts that are requiring the vaccine once it's been licensed to individuals who are eligible. A couple of those have started happening. And we have many workplaces that require it as well. The data that this goes back to September, but again, the trend's been pretty consistent, and we broke this down by urban, suburban, and rural, where it's much more likely that individuals who live and work in urban areas have a requirement for vaccination in the workplace versus individuals who work in rural areas. As we're looking at different indicators and thinking about implementing programs, this sort of creates an opportunity and aligns with some of the challenges that we've had throughout the pandemic in terms of looking at food manufacturing, food processing facilities with lots of essential workers, many of whom are in specific racial or ethnic minority groups, and being less likely or interested in requiring vaccination. There may also be an effect where we know that there's a higher concentration of healthcare providers in urban and rural areas, and health professionals have been much more likely to be required to get vaccinated. So there's a lot of different pieces going on here in terms of understanding why and thinking about how you might build a strategy looking at the different data that you can get from these reports. Next slide. And so here's a couple of examples of maps looking at both vaccination coverage and comparing and seeing where those different indicators are on the behavioral and social science side. So on the left-hand side, we have a map showing where unvaccinated people are. So there's a slightly darker blue on the map on the left-hand side where individuals, you have a higher percentage of individuals, 20+% of individuals age 18 and older who are unvaccinated, highlighting some specific states. There's a large chunk in the Southeast going up to the Midwest, up to Michigan, a line going up through along the Mississippi, and then over through some of the northern western states, Idaho, Montana, et cetera. And then on the other side, when we look at sort of those social factors or those influencing factors, the perception that people see the COVID-19 vaccine or they're confident in the safety of the COVID-19 vaccine. There's a significant alignment in states where you see many of the southeastern states several of the Western states, several of the Midwestern states, and there's states along the Mississippi, kind of having that there's a higher perception that the vaccine is not safe. And the lighter color shows individuals who do not perceive the vaccine as safe. And there are some outliers though. Places like New Hampshire, as well as Massachusetts, there's, while they are much more likely to get vaccinated, have much higher vaccination coverage, there is a higher perception that the vaccine isn't as safe. The irony, my family is from Massachusetts, so I'll say this with my own anecdotal observation. The conversations I've had with my family members about quote unquote very stubborn Yankees in Massachusetts and New Hampshire in particular is a very common trope and stereotype, and we may see that reflected in that data as well and explain some of that, the outlier. There's also, because this is aggregated across all adults, many groups, individuals that start out with lower trust, lower confidence in the system, it may be reflecting that as well in those communities too. Next slide. And I will just kind of stop on this for a little bit. These are data that we get from the Household Pulse Survey. They really kind of give us a lot of confirmatory information, looking at children who reported getting vaccinated. So showing 3 maps across. On the left, children who reported getting vaccinated, percentage of households who will probably get vaccinated, and percentage of households who will probably not get vaccinated. So again, giving us another layer of their perception and also some confirmatory data. Next slide. Again, looking at some of the information gaps and some of the understanding that we might use to really drive some of our strategies and approaches. The Kaiser Family Foundation, their surveys that they've done have been pretty consistent. And this one really gets at the reality that individuals, families who either do not perceive as much risk of disease or who have been less familiar with vaccine because it hasn't been recommended for their age group as much. So it's newer, it's less normalized. The awareness and comfort with the information that's available is reflected in that. So this shows that we have how important conversations are, how important that interaction is in making sure that we are answering questions and showing and demonstrating the safety and effectiveness of the vaccine. Next slide. The insights report we've done, highlighting some things here. Please go online and take a look at it. And if you don't receive these reports regularly, you can get them. We're about to do our 25th version. So these data reflect information that we did on a special report on pediatric vaccination, themes around that. Again, around children, the reporting around myocarditis, concerns about health and safety of vaccine, long-term, unknown long-term side effects, and then persistent concern about fertility around pediatrics begin to really kind of are themes that come out. And this is where the risk perception, again, of the vaccine versus the disease really kind of come in. And seeing the issue of milder symptoms versus stronger immunity, fewer deaths. But at the same time, we know that there are data that show a very different perception. It's working and understanding and getting people to kind of pull out of those initial perceptions that are lingering. We also have the urban-rural vaccination difference. is persistent among children pediatric vaccination as well. So take a look at that report. It adds, again, some more depth to the understanding. Next slide, please. All right, so I will go through some of the concepts. I saw a note in the chat. I wanted to spend a lot of time talking about the data, and I'll move pretty quickly through the concepts so that we can have some time for Q&A and discussion. Next slide. All right, so I mentioned this before, everything about vaccine confidence is really based on trust, but it's not just trust in the vaccine. It is reflective of trust in every aspect of the system and everything that goes into it. So anything that talks about, and we'll see much more coverage of myocarditis, which is a very minor issue, a very small percentage, but something that we are working hard to understand. We see more reporting and discussion about that than sometimes about the real risks of the disease. So again, trust in the system, trust in the vaccine, what we see, how what we see sort of normalizes and drives our perception and understanding. But the trust is the key, and trust is based on relationships. Next slide. And when we talk about vaccine confidence, we look at it on a continuum. Again, this gets to that trust issue. The greater trust, the greater confidence in the system, in the vaccine and everything around it, the greater demand, and the least trust is aligned with the most likely to not get vaccinated or not want to get vaccinated. And those individuals, and it's a continuum, everybody can be at a different place at a different time. I know even as somebody who sees all the data, I was, until I started seeing the data, until I started understanding the data, I had plenty of questions about the mRNA vaccine. So very natural, very normal to have questions. So it's very dynamic. And so demand kind of shifts and confidence shifts as people get more information, as they engage in the system and create trust. Where we sit normally in the United States, because particularly for childhood vaccination, is in this middle place where we have sort of passive acceptance of vaccination because it is so normalized and part of our regular system. So these individuals in this vaccination point, what has been deemed colloquially as a movable middle, are individuals who may take a wait and see approach or need a particular nudge to get vaccinated. Next slide. Talk through the behavioral and social drivers again. I just wanted to highlight where this fits into the process again, and reiterate that this is central to all of our strategy development. Next slide. And this is really kind of the ladder for building vaccine demand taken and takes the behavioral model and kind of turns it upside down, understanding and reminding that, how important access is in building vaccine confidence and demand, understanding the benefits, understanding creating convenience, making the vaccine desirable, normative, something that's a social default, and then necessary. And this is necessary is where we start to get into mandates or requirements. The reason that's last is because it requires the normative aspect and everything else being in place before you can begin to do that effectively. And we've seen, as you see in the political aspect of things and in those discussions, some of why all of those other things have to be in place before you can sort of really start doing requirements or mandates. Next slide. Just a note about the term hesitancy. I've said this before, you guys probably heard it from others. We look at vaccinated or not vaccinated, or not yet vaccinated. We never assume hesitancy. We really kind of focus on the specific barriers and the facilitators and where we can build relationships and connections with the system, and understanding that, because assuming hesitancy normalizes hesitancy, and it puts the burden on the individual instead of helping us understand how we can create facilitators and remove barriers to vaccination. So it really kind of, it's a phrase that we don't use that we're trying to kind of wipe from our lexicon, and just kind of framing that in terms of how we're thinking about it, and how we're approaching things. Next slide. I also wanted to highlight, as we're talking about data and talking about evidence, how important conversations are. There was a paper that came out in October of last year that looked at the drivers of vaccination. And what they found, and we've seen this play out in programs as well, is that incentives are really great at nudging people who are already interested. So in that group of, I'll probably get vaccinated, but they're not very effective in reaching individuals who are in that group of probably won't get vaccinated. So understanding kind of how all of those different things play in. Next slide.
Hi, Richard. I do see a few questions in the chat. I don't know if we're going to have time to get to them, but would you be able to answer them if I send them to you, and maybe we can put it on our virtual platform?
Yes, I can definitely do that. And I will look at them just real quickly. If you want to advance, well, you can share the slide set as well. Just looking at some of the questions, the participatory assessment process, and you can just keep clicking through this one. The participatory process is a rapid community assessment. We've got links and information about that. Actual number of individuals, I don't know what that question refers to. And then applying data to increase vaccination uptake. I think I will sort of stop on that question. And one of the things I think is really important in understanding data is a starting point. Data is a starting point in understanding the community. And that's firstly how I would apply quantitative data, and then I would take the approach of understanding and digging deeper into the qualitative aspects of it. Quantitative data is great, but it is not always understandable, real, and perceived as relevant, whereas qualitative data, understanding people's lives, and understanding what's going on in the community and applying that, gives you that full picture so that you can use those two things plus your own perceptions and understanding and gut instinct to be able to drive how you reach communities and make connections.
Okay. Thank you so much for such an awesome presentation, showing us how we can use data even in putting in our own programmatic efforts. We do have a brief satisfaction poll, so before we start losing people, please just answer our poll really quickly. We use this to try to guide our future programmatic efforts. And also, we will have all of the slides as well as the recording of this presentation available on our virtual platform. So for the slides that we didn't get to, we'll still be able to see them. And Richard also said that he'd be willing to answer the questions in the chat. So we'll put that on the platform as well. And if you don't have access to the platform, again, the link should be in the chat. So just fill that out and we can give you access to that as well. But once again, thank you so much, Richard, for joining us. This was a very enlightening presentation, and I'm sure that all of our members really appreciate your efforts.
Thank you. I'm happy to be here, and I'm happy to come back and talk through maybe some of the other concepts and resources and things now that we have a more consistent understanding of all the data sources, and dig into those aspects of it a little bit more.
Great. Thank you so much.